Now, in the past 6 months, the United States has been in an uphill battle against the fight of COVID-19. The number of Americans infected continues to rise. Recently, we're topping 5 million infected, and the death toll is approaching 180,000. And since the first case of COVID-19 was diagnosed in the United States in January, followed soon after by the World Health Organization declaring it a global health emergency, COVID-19 has upended just about every aspect of life as you know it. The pandemic has taken its toll on the economy. It's frayed the fabric of our social networks, our personal lives. It's stressed and strained our healthcare system to epic proportions. Now we know there are multiple platforms that we use to test for COVID-19, and the research has given us, fluctuating and understanding what we need to do to look at what this disease looks like in the short and long term. But although the system has been a little slow to implement the needed testing at the rates required by our citizens, which increases the vulnerability of our populations around the country, there's been significant progress. And now therapies are being developed, and hopefully, as you know, vaccines are getting closer. But with 6 months of this pandemic behind us, we can't help but take stock of where we are in the fight against COVID-19. And while some states have progressed to a place where they can safely reopen some businesses or even schools, other states are still mired in spiking numbers of cases. And now, with summer quickly coming to a close, and as we transition to a new season, we have to look ahead to where we're going to go from here as this virus rages on. What we have to do and the work we have to do to tirelessly slow the spread of this disease.
So I will not belabor what I think we've probably all seen many, many times. We know we're dealing with a SARS virus, and we can see from the image on the left that these are viruses that exist in animals and, of course, can and have been transmitted to other animals and to humans, and then we can have human-to-human transmission by a variety of mechanisms. A really great base article I have referenced here for you from Clinical Microbiology Reviews. So if you want just a great background of SARS-CoV-2 and COVID-19, it's a great standard reference. So what do you do when you've been asked to test for a virus that you've never met and your leadership wants it done yesterday? This is something that we've all lived through, and we've all had a different experience. I'm going to share our experience and some of our learnings, and I look forward to hearing back from some of you about yours. So first of all, the Food and Drug Administration, as you know, has an emergency use authorization, and that's what we've all been using to have tests available for this virus. At first, this was limited to public health facilities, but it became immediately obvious that our public health infrastructure, which we'd love to do more and more to buoy up in the future, was being overwhelmed by this coming tsunami, as were many of the other laboratories that would bring up EUAs. So the federal government opened diagnostic testing through the EUA process to diagnostic vendors, to commercial reference laboratories, to academic institutions, etc. And in this way, we were basically given the green light to bring up SARS-CoV-2 testing. And so what this demonstrated is laboratories that had molecular expertise were able to do this, and laboratories that had limited expertise in these areas were really reliant on diagnostic vendors or had to send tests out to commercial reference laboratories. Real opportunities here for us to look at building our laboratory infrastructure, building your molecular expertise if you were in one of these categories I described, and of course, as mentioned, building our public health infrastructure. So first of all tests are not created equal, and we know this from being laboratorians and doing this for a living. And the first call I got from my clinicians when we presented the test that we were going to go live with, which was the CDC test, was, what's the sensitivity and specificity? And I had to tell them I don't know, because those studies had not been done, right? This was an emergency use release. It was not, there were not really clinical trials done like we'd expect with a full FDA submission trial. And so what I had to tell them was what we did in our laboratory for validation. And what we did was we essentially repeated everything that was needed to be done for the emergency use authorization, but also did some additional studies, probably more to make us feel better, but we did them anyway, assuring no cross-reactivity with circulating common cold coronaviruses, etc. Now, the emergency use authorization is a good entry-level criteria. What do you do in an emergency? And so we give them a lot of credit for putting this together, and there are many good things about it, but as many folks use it, it becomes obvious where fine-tuning could occur. And, you know, as we all try to work to make things better, I'm sure FDA is and will do that for future uses. For example, some of the great things, they required in silico analysis of primers and probes to determine that there would be no cross-reactivity, etc. They asked for a limit of detection, and you could provide a limit of detection, but they did not provide any guidance around what was an acceptable limit of detection and an unacceptable limit of detection. So those are some areas where there could be improvements. So what we did was, as mentioned, we first came live with the CDC assay, and then after that, we brought up 4 more assays, and we were investigating the Abbott ID Now, and essentially what we did was we did a 5-test comparison, and this was really our opportunity to look at analytical sensitivity and specificity, and how we define that. And we've done this before with other papers, is we said if any specimen tests positive with any one of these tests, and that specimen is corroborated by another test to be positive, then we're going to say that that specimen contains SARS-CoV-2. And comfortable with that definition, and this paper is essentially accepted for publication, and this should be out soon. Wish it was out earlier, just buried in COVID-19 testing. But anyway, you can see when all 5 of these tests are assessed against the same criteria, differences in analytical sensitivity and specificity become clear, particularly analytical sensitivity. And at this point in the pandemic, that's what we were most interested in, diagnosing patients with potential disease, particularly those that were going to come into the hospital and go into a COVID-free or a COVID unit. So we wanted to make 100% sure, as close to 100% as we could get, to make sure that those patients did or did not have SARS-CoV-2. So this is how we did our comparison, and that was a useful way to really understand differences in limits of detection and which tests we wanted to use to bring patients into the hospital. So next is, how did the entire team work? And this was a great learning experience. I point you to a write-up by Dr. Reddy. The reference is at the bottom, and the next few slides are going to deal with how we dealt with this pandemic at Cleveland Clinic. And, you know, I give our Chief of Medical Operations, Dr. Bob Wiley, credit for being our incident command leader. He has pulled together a team that will respond in any incident, right? And so we came together, and most incidents are not long-lasting, right? Fires, tornadoes, you know, etc. But this one turned into a process that continues to this day. But bringing everyone together, a really systems-based practice approach was just absolutely critical to have everybody on the exact same page. So on the incident command team, all aspects of medical operations were present, including laboratory, right? And we actually ran tabletop exercises running worst case scenarios to determine how we would handle those. In the beginning, we would meet twice daily. We would report on current states. Representatives would report out on their particular areas. Individuals were assigned tasks. There would be subgroup meetings to accomplish those tasks, and then there would be follow-up. So really an amazingly organized way to deal with chaos, and it's exactly what you have to do. And just some of the highlights, what did we have to do? Well, we had to know where we were with things, right? And so, you know, huge amount of credit and kudos go out to our informatics teams who were able to build enterprise dashboards so all these different groups could actually see the amount of testing that was being done per day, the positivity rate, etc. So you got to have strong informatics. Part two is we had and still have to this day, and I'm sure you do, limited allocations of testing materials. How are you going to use those? We only had so many Cepheid reagents, which was our rapid testing platform. How are you going to use those? Because if you don't use those wisely, those will all be used up, and then the patients that really need them the most will not have them. And who has access to routine testing? Is it everybody who wants to test can get a test? You'll see that's not the case. And we did, until just recently, limited even our symptomatic patients to those in higher risk. So Dr. Reddy, who wrote that paper, leads with Dr. Hendricks our laboratory stewardship committee and have taken control of SARS-CoV-2 laboratory stewardship. And so, again, a team-based approach to how are we going to handle situations of limited allocation. So, and then working in our MyChart, developed, so again, through this team, home monitoring programs for patients who were positive but as outpatients. So really some great things that come out and always come out of this team-based approach. So let's move on to healthcare workers that have had COVID, recovered, and now we need to get them back to work. How do you get them back to work? And these were the criteria at that point in time. And so at that point in time, you had two options, a test-based strategy and a non-test-based strategy. And we chose to use the test-based strategy. That has subsequently changed, and I'll show you the data why. But you needed 2 negative tests to return from work, to work after having COVID, after having recovered from COVID. And so it was challenging because we were bringing back very few healthcare workers. They test negative one day, positive the next day, or positive later in the week. So what was going on? We couldn't get these important critical workers back to work. And so if you look at this slide, this demonstrates the same patient's initial viral load in red and their subsequent viral loads in aqua. And you can see that when you plot this against the time from onset, as they get further and further out from their initial diagnosis, their viral loads decrease. And so that is going to end up being a theme in the next few slides. And so one of my colleagues, Dr. Shrestha, wrote this great paper and essentially did the studies that allowed us to bring patients back in a non-testing scenario. And the reference will be given, I believe, on the next slide. So what we did was we looked at different time periods and looked at those viral loads, and you can see that by day 15, so right after 2 weeks, you have an over 32,000-fold difference in the median viral load from onset. And so this, in conjunction with some additional evidence, was used to bring these patients back to work. And so what's going on here? What are we detecting? And so you can see, again, his paper and reference on the right, as well as another paper looking at viral shedding dynamics. And so essentially what we know is COVID-19, when you survive this, has a long tail to this curve wherein you will be PCR positive but non-infectious. And why do we think that patients in this long tail of convalescence are likely or absolutely non-infectious? Well, a couple reasons. One is there's a South Korean study that looked at these folks who went home and they did not pass on COVID to their family members. And we know being a family member of somebody with active COVID-19 is a high risk for contracting the disease. So the fact they didn't pass it on suggests that it's non-infectious. Probably a non-infectious viral fragment still detectable by highly sensitive RT-PCR assays. And here's a German study, a reference given, that looks at the ability to culture virus over time and associated with viral loads. So again, as disease progresses, patients get into convalescence and viral load decreases, the ability to recover viable virus or virus that is able to replicate it decreases with time. So this is how we brought patients back. We eliminated the two-test strategy and went to a strategy that looked at symptoms, time of symptom resolution, etc. And after 2 weeks, we're able to bring most folks back to work. Now let's go back to our 5-test comparison, because as you recall, there were 2 assays, the Diasort Simplexa and the Abbott ID Now, that did not perform as well as the other 3 assays with regards to sensitivity. All these assays are highly specific. And so why do we think that was? Well, both of those assays eliminate the nucleic acid isolation step, the extraction step. And, you know, ask any molecular biologist worth their salt, and they were probably raised the way that I was, and that the best way to get the most efficient PCR is with a clean nucleic acid substrate to start with. And we understand that there are great assays that are out there that skip this step, and it's fine to decrease some analytical sensitivity if you don't compromise clinical sensitivity. And that's something that needs to be determined. So what were we missing in these 2 assays that had a slightly lower sensitivity? What we were missing were these folks with lower viral loads. And so again, that's not surprising. This was occurring at the same time we were studying our healthcare workers, and these were folks that were getting over COVID-19 and their symptoms were resolving and they had low viral loads. So that's what was being missed by these 2 assays, which again will inform how to use these assays. So one of the themes I'd like to bring across is there's no such thing as a good test or a bad test. There are just different test performance characteristics. And once you understand those performance characteristics, you can work with your clinicians to utilize those tests in the best possible ways. So I don't have a lot of slides on antigen or antibody testing, but we do need to talk about those. And so antigen testing is attractive because it's inexpensive and quick. But we know from years of antigen testing for other respiratory viruses, influenza, for group A strep, these are always less sensitive than real-time PCR. Again, usually equally specific. So it all matters, and this is going to be a new theme that we're going to go deep into, is it all depends on the patient population you're testing. So if you're testing symptomatic patients, a positive equals a positive. But if you're testing somebody who looks like they have disease, be it COVID-19 or strep throat, and this rapid test that lacks some sensitivity is negative, you need to follow it up with a molecular test. Now let's get into how to use these in asymptomatic people. This is even more complicated in that we know it's a less sensitive test, so we're going to miss folks with lower viral loads, and that could be early or late in disease. And then, regardless of the test, not just antigen detection tests, and we're going to go into this again deeper in the next few slides, is you increase your rate of false positives. And again, we'll go into that in great detail, so not belabor it here. Antibody tests. I can't believe the amount of time that we have wasted as a country on antibody testing and everyone looking for, the golden solution. We don't use antibody tests for any of the common respiratory viruses. You don't do antibody testing for influenza. Why do we think it would be good here? Well, we've learned a lot through all of this time spent, and it is not a diagnostic test for COVID-19. There's a variety of reasons and long, great lectures on this, but there are both false positives because of cross-reactivity with common cold coronaviruses. There are negatives. These are late. Immune response occurs later in disease, and there's no evidence of long-lasting immunity. These are useful for public health surveillance. That's what they're useful for. And so let's see what the CDC has to say about these tests. For antigens, they say, just as I mentioned, it may be necessary to confirm a rapid antigen test with a nucleic acid test, especially if the antigen test is inconsistent with the clinical context. If you think the patient has COVID-19 and you get a negative, you got to follow it up. Antibody testing. Food and Drug Administration has not authorized antibody testing to diagnose COVID-19, and CDC does not currently recommend antibody testing for diagnosis of any infection. So you get the idea of where these are useful and where they're not. Antibody testing needs to stay for the current state in public health surveillance. So it's all about testing. Anyone who wants a test can have a test. We've heard that. That is not right. And so this is what happens when you are testing without a plan. Everybody, and this includes a lot of worried well, are in line for hours without a great plan on how to follow these people up, etc. It's a mess, and there's backups of weeks at commercial reference laboratories, meaning that patients who actually need a test and a rapid result are not getting those because of the lack of a strategy. So grab a test, any test, serology, less sensitive molecular test, highly sensitive, antigen, what do you want to do? No, this is not the approach either for some of the reasons we've already stated. So how about, it's all about using the right test in the right patient care setting with an understanding of how the test performance characteristics, which we described, and the prevalence of disease affect positive and negative predictive value. Bam, we got it. As we move on to the end of the lecture, I wanted to distill down some pearls I hope you got from this time. And the first one is know your test performance characteristics. And so by that, you really need to compare it with other tests and have clear definitions of what constitutes a positive and what constitutes a negative. Then you have to know the population you're using your test in. Know how prevalence or the pretest probability affects the post-test probability. And I will tell you, I've had to explain this to, our physicians here. So this is something that's probably learned in medical school, and if you're not a testing person, often forgotten, unless this is really part of your practice. So, a test is not a test is not a test. Both first understand those performance characteristics, then understand the population it's going to be used in, and forget about serology unless you're in the public health arena and going to do public health surveillance. Then go for it. Otherwise, it's really not useful here in SARS-CoV-2. Saliva, it looks like a viable option for testing symptomatic patients for sure. It'll be interesting to see studies on asymptomatic patients. The other issue we ran into with saliva with flu season coming is you would have to collect 2 specimens if you wanted to do both, flu and RSV or flu and SARS-CoV-2, unless you're going to also validate saliva for influenza and RSV. So that's another, that's one of the reasons we have not implemented saliva, because of the potential to either have to validate it or use another specimen type for influenza testing. And what we're going to do during flu season is on all symptomatic patients test for flu A, B, RSV, and SARS-CoV-2. So that kind of limited our ability to utilize saliva. We'll see, it may have its use someplace else, but not for the moment here at the clinic. Pooling may miss some people with low viral loads, but doesn't matter. That's the million-dollar question, right? And again, this comes into what are the patients you're testing, what are the likelihoods of bad things happening to them, bad things happening to people in the hospital if they're going to be admitted. So you got to really talk about a risk-benefit assessment if you're going to do this, and put the guardrails of education around it. So in conclusion, tests are tools, and you can see from this picture things that we would never do. You know, we don't drive in screws with hammers, and we don't use, you know, wrenches on nails, right? So tools should be used correctly, and I think you know, got the idea from this lecture around that. And, you know, as I've heard said by others, you know, we cannot test our way out of this. There's no simple pill to make you lose weight. There's no simple pill to keep us fit. There's no simple pill to get us out of the COVID-19 pandemic. We're going to have to do the work on any of these things if we want to get to the conclusions and the outcomes we want. So we're going to need to employ all the mitigation strategies: wear the masks, practice social distancing, good hand hygiene and the like, and use testing where and when appropriate. So with that, I thank you for your attention, and I hope you found this talk useful.
Thank you. And Dr. Garner, I'd like to ask you to share with us within your facility, your laboratories, how do your lab managers help ease other employees' concerns around the safety of processing specimens and obviously clearly being part of the front line of the testing services for this particular pandemic? What do they do? What are best practices they can share to help alleviate the concerns of even your employees?
So one of the things that we have been doing is obviously using universal precautions. That started with the first pandemic that I was involved in, which was AIDS, and it continues to exist. But that changed our laboratory practices. And nowadays, we're definitely continuing to use our lab coats, our gloves, our masks. Actually, it was interesting because in the hospital, we weren't using universal masking until a few of the units units that did not have patients with COVID ended up with nurses getting infected. And so they established universal masking for the entire hospital. And so since then, everybody has been using a mask in the lab. When you're around the hospital, you're using your mask. One of the things that I've been trying very carefully to work with my team is from the very beginning, we started talking and asking, I asked them questions. What are you worried about? What can we do to protect people? And I think one of the biggest and most important things is to let the processors, the phlebotomists, the techs ask you questions, and you answer the best you can, because we're obviously learning a lot as we're learning with this pandemic. But being able to ask questions and to make sure that people understand all the different things that they need to protect themselves. Obviously, if they're working with respiratory secretions, they need to be under a hood, using their gloves, And then for other specimens, they can use the regular precautions that we use in a lab. One thing that we have definitely done is we've asked people to walk any respiratory specimen to the lab rather than sending it through the tube, which is something that has been, there's been a lot of back and forth, but we're asking people to walk the specimens that are any of the respiratory, nasopharyngeal, BALs to the lab.
So let me piggyback on that and ask Dr. Geller how she, in her laboratory, in your laboratory, how do you implement, or how has personal protective equipment, as Dr. Garner said, or social distancing affected your workflow within your laboratory? How does it affect the workflow? How has it affected the turnaround time? How's it affected maybe even the morale of your laboratory staff as you have more and more multi-platform testing coming online? Tell me a little bit about your experience and what you're seeing and some lessons learned.
So I can speak to our experience at the medical examiner's office, where I spend quite a bit of time. The workflow wasn't changed too much for us by adding a N95 or making sure that we are covered with a impenetrable gown. Our turnaround times haven't really changed at the ME's office, but we have done to improve morale. We, like Dr. Garner, have wanted to make sure that people are heard. And so the only people doing autopsies are those that have, the only people doing COVID positive or COVID suspected autopsies are those that have volunteered to do so. And we've done the same thing at Emory, that there's a dedicated team of us that are the COVID team. And there's dedicated staff who have also volunteered to do these cases. So people that aren't comfortable with being involved in a COVID case do not have to do that. And we've also, I would like to show a prop, we've also purchased a fogger that we are using at the medical examiner's office. Okay, this is what you would normally, I guess you fog for bugs, but you can put a hospital-grade disinfectant in here, and you can fog your space after performing an autopsy, and it kills everything. Daycares do this, sometimes just for disinfection, and it makes people feel good to know that you care about the space, that they might have to come in and grab a specimen, or they might have to restock some tubes, that you are cleaning up their space and you have their safety in mind.
Now, that was the first prop we've seen on the town hall, so thank you for sharing that with us. You can buy it at your local convenience store, or do we need to contact you for one of these apparatus?
I guess I should have disclosed that I was going to promote that, but I think they were. I think they had to drive around town, but were able to find one at Lowe's or Home Depot. Okay,
thank you for that, Dr. Salerno. I'd like to get you to share with us your experience. Tell us a little bit about examples of both in your practice strategies that you've used to prevent or minimize the transmission of COVID-19.
Sure. Let me just clarify a little bit so I'm not misrepresenting myself. But so I'm not responsible for laboratory testing and work at CDC itself. My division is really responsible for engaging the clinical laboratory community, and in particular, we are responsible for drafting biosafety guidance for the clinical laboratory community. So, really how I can answer that question is to talk about, what we have heard through our engagements across the country with many, many different institutions. And, I think what's I wanted to emphasize today is that many of the things that we normally preach are fundamentally important to minimize COVID-19 transmission. So, and some of these things, Dr. Geller and Dr. Garner have already highlighted, and the importance of standard precautions, right? Which is hand hygiene and the proper use of personal protective equipment. Limiting access to the laboratory, minimizing the number of staff who are working in this with this responsibility, ensuring personnel receive appropriate training and specific COVID-19 training, ensuring that everyone understands that we're talking about droplet transmission here as the principal risk, reinforcing the importance of risk assessment, and particularly site-specific, activity-specific, and even instrument-specific risk assessment to understand where contamination could be occurring in the laboratory, where there could be splashes or aerosols, and specifically addressing those issues with the whole staff or whoever's working on COVID-19 activities. A reinforcement of decontamination of work surfaces and equipment processes, a reinforcement of what we have always done in terms of decontaminating cultures, stools, and other potentially infectious materials before disposal, reinforcing, how we pack and ship and send, whether it's specimens, cultures, or isolates, by category B standards. So I think all of those things have been part of biosafety practices for a standard BSL-2 laboratory for some time, but this is a good opportunity to reinforce many of those historical measures. And then obviously, in addition, we've added and encourage, and we see lots of other things being done to enhance protections. We all were wearing personal cloth face coverings when we're sort of not associated with direct laboratory work, more frequent laboratory cleaning, more frequent personal hygiene, adjusted staff schedules have already been mentioned, reducing the number of face-to-face meetings and interactions. We've even heard of one-way hallways being established in facilities, decreasing the density in laboratories, reconfiguring workspaces and shared equipment to reduce crowding. So those are a number of measures that we've heard have been implemented in addition to sort of what we would consider to be standard biosafety level 2 practices.
Do you have any guidelines, Dr. Salerno, around both internal and external transportation of COVID specimens?
Yeah, I mean, we've been asked many questions over the last few months, in particular about pneumatic tube systems. Dr. Guarner has already mentioned that, and the CDC guidance sounds to be exactly like what Emory is doing, which is for respiratory specimens, not to rely on the pneumatic tube systems. But we have said that we believe that non-respiratory specimen types can, if necessary, can be shipped internally through the pneumatic tube system. Again, what's really important from our point of view in terms of internal transport safety is risk assessment, an evaluation by every facility of how they do transportation, who's doing it, are they adequately trained? Even for those who use the pneumatic tubes, are they adequately trained? Do they know how to do spill decontamination? Are they prepared to be transporting a respiratory specimen that could contain COVID-19, and so on and so forth. In terms of external transportation, as I mentioned before, the CDC guidance is for whether it's patient specimens or cultures or isolates to follow UN 3373 for category B biological substances and follow IATA regulations for category B. Thank you.
Thank you. Let me ask Dr. Garner to weigh in on what was just said. So there's guidelines from the CDC. And these biosafety guidelines are obviously to protect the personnel, but have you found those guidelines difficult to implement, or have you seen any challenges, unique challenges surrounding those guidelines? Are we, I guess what I like to say is, are we taking to the step where we're trying to prevent ourselves from preparedness like we would treat an Ebola specimen, or is it to that degree? Share with us your opinion on how the guidelines might be implemented.
I think the guidelines are easy to follow in general. I don't think that it has been any more than we should be doing. And I think one of the things that I think is important is that to me, it's really interesting because people become lax when there's no major thing going on, but as soon as something is happening, they get tense, and then they start being much more careful about, you know, cleaning the hood and putting the UV light and closing it when they're not using it. So to me, I think we should be continuously using those guidelines because they protect us all the time. It doesn't matter if it's COVID or influenza H5N5. It's continuously helping the worker to deal with all the stuff that they're dealing with. And the fact is, we really haven't had anybody in the lab getting sick. The people that have gotten sick, if they have been because they've gotten infected in the community. And to me, it's more dangerous to do a pad in a gas station without gloves or a hand sanitizer than what we're doing in the lab, where we're hand sanitizing our hands all the time, where we have gloves that we can use all the time, where we have our gowns that we're using. So in some way or another, I feel like we need to take those precautions to the community where we're more in touch with other things that other people have touched and have not used the precautions. What we're using in the lab is actually pretty good, I would say. We never used this kind of thing for the Ebola patients that we had at Emory, that's for sure. Could we implement something like this if we had so many patients with Ebola? I guess we could. It would be something that could be done. Not that I want to try it, but but if we had, you know, so many patients as we've had, I guess you couldn't isolate them in what we call our SCDUR unit, where we had our Ebola patients, and then we will have to take care of them more as we're taking our COVID patients.
So you just described a journey, however, through biosafety in terms of becoming more vigilant. So are you saying these are permanent changes going downstream past COVID and whatever we're looking into the future, or maybe even other pandemics or the return of this particular virus? You think these are permanent changes that you're going to implement from here on?
Shut people out for sure.
I would definitely like to make sure that people are doing this, because I think we've seen how influenza has completely plummeted. We've had no cases of influenza since we've been using all the precautions. So I think we need to be, I think we need to keep on doing what we're doing.
Dr. Salerno, do you agree that these are maybe permanent changes in the history of your career and all of our careers? Now we're becoming extremely vigilant in the laboratory. And as Dr. Garner said, it's provided a layer of protection that even the public has not necessarily been able to enjoy. What do you think about the new normal? Or is this going to be, we're going to go back to the way we were practicing biosafety before COVID?
Well, I really hope it's a new normal. You know, I think honestly, clinical laboratory biosafety in general has not received historically as much attention as I've always thought it deserved. And what COVID has done is brought to the forefront the importance of biosafety to the clinical laboratory community. In ways also that previous outbreaks have done, but the fact that COVID is such a dramatic event compared to previous public health emergencies has given us, I believe, in this community an opportunity to really stress the importance of laboratory biosafety and to reinforce, as my colleagues have done, the good practices that, you know, I think we all knew about and we all know about, but we really haven't, in general, been serious in the past about implementing them on a regular basis. And I hope that, all these steps that we're taking for COVID-19 laboratory biosafety will be embraced throughout COVID, but also in post-COVID environments, and that this is a great opportunity for all of us to remind ourselves about the importance of biosafety and to teach our colleagues about the importance of biosafety.
Well, I think maybe it's safe to say in general that we've all seen an evolution in the type of biosafety that's been implemented in the laboratory from 4 months ago to today. If you want to go back in reverse and think about your laboratory in January and in the clinical laboratory, whether it be medical micro or whatever it might be, virology, you would be looking at a different type of biosafety practice. And I think even as you think about your own practices and as you travel and support clinicians or practitioners across the nation, the vigilance is definitely being taken more seriously. And I think you're right, Dr. Schiller. I think this is the new normal. I think it should be the new normal because we don't know the pathogenesis of this disease, nor the ones that are coming after us. So thank you for issuing the guidelines and working on guidelines to support the healthcare of our practitioners. We're going to be looking at COVID-19 in the patient, but more importantly, how it has further exposed and escalated existing healthcare disparities in the United States. Let's start with some stark statistics. According to the CDC, because of longstanding health inequities, some racial and ethnic minority groups have an increased risk of contracting COVID-19 over other populations. American Indian, Alaskan Natives are 5 times more likely to get COVID. Black Americans, African Americans are 5 times more likely to get COVID. Hispanic or Latino individuals are 4 times more likely to contract COVID. And these are significant differences. They're all stemming from across all age ranges and across all states in the United States, despite the fact that we are, in most states, implementing measures to protect our citizens with sheltering in place measures, mandating the use of face masks in many states, and encouraging social distancing. However, more than 130,000 people have still died from complications related to COVID-19. And while the data is still emerging, and as you know, this pandemic is escalating, we've seen those numbers of deaths disproportionately affecting our Black and Hispanic Latino populations. The number of deaths are 2 to 3 times greater than other populations. And these statistics, albeit sobering, and the impact of COVID-19 is having on vulnerable populations is critically important, and it cannot be ignored. Last week we had a great conversation at the town hall related to healthcare disparities and issues for which some patients are at a more severe risk for this particular disease. And I'd like to stick with that conversation for a minute, Dr. Call, because our nation is embroiled in issues of disparities to some degree. We're actually fueled by the pandemic, correct? I mean, they were there before, but now the pandemic has fueled it. Do you think healthcare for underrepresented minorities will ultimately benefit from the pandemic, or is it making the situation worse?
You know, it's probably making it worse right now, and I have hopes that it will benefit, because I think this is a time when we're all, really looking at how we operate within our institutions, but also across our systems and what we can do better. We had a conversation yesterday within our institution, just looking at how can we share our capacity for testing with other institutions. And I'm proud to say that we have helped others in the Chicago area. Similarly, we've shared convalescent plasma, but many of the less socioeconomically blessed institutions will have a hard time putting together either testing or treatment. And I think, we need to really pay attention to that and make sure that these resources are fairly used.
I'm not sure if anybody else would like to comment on this, particularly Jasmine, maybe from the federal level. You opportunities here. What are your thoughts?
I think this is an important issue, and CDC is looking at it. And I'm not involved in that particular task force that's focused on that, but I will say that this is related to some of the reporting requirements that were recently asked laboratories to provide to public health and ultimately to CDC. This is related to guidance that went out from HHS, related also to the CARES Act, which requires laboratories to report data to public health. And there are some data elements in there about race and ethnicity. And we realize that there's a burden for the laboratories to collect this data, but it is important for us to be able to understand the impacts to different ethnicities and races.
So let's get straight to the heart of the matter. Dr. Fauci, again, thank you so much for joining us, and appreciate you making a way across town from the congressional testimony to have your dialogue with us today. We are thrilled to have you. And let's just jump right into a question that all of us have been thinking about. I want you to walk us back to the beginning of this year. Walk us through the days of SARS-CoV-2 before it was even diagnosed in the United States. And what was going on? What was going through your mind? And do you think as a country at the time, do you feel like we were ready for it to spread the way it did through this country?
Well, it's really very interesting that we had, as a country, which is multiple agencies, NIH, as you well know, is responsible for the basic and clinical research for the development of understanding of disease and the development of countermeasures like diagnostics, therapeutic, and vaccines. And there's the CDC, and then there's BARDA, the Biomedical Advanced Research Authority, that essentially purchases and finances companies to take risks to make products that we would need for an outbreak, but may not be necessarily something that's a blockbuster drug for a company. And we have the FDA, and we have a number of agencies. If you put them all together and look at our pandemic preparedness plan, antedating this by years, was judged, by Johns Hopkins University, as being the best pandemic preparedness plan of any country in the world. And yet, interestingly, we got hit worse than anybody else in the world, which tells you that, you can never be absolutely prepared for aspects of an emerging infection that in real time, you're learning just exactly what it is. And really from those very first days, although we had plans in place, things did not work right well at all in the beginning. I think particularly in the thing that's most notorious was in the early days, our lack of ability to get a good testing program going. That was the first thing. And it took a long time before we had not only the tests, but the capability of effectively identifying, isolating, and contact tracing. So that was something that everyone recognizes now as a misstep. The other thing was the lack of appreciation, and we really had no way of appreciating it until it sort of became obvious that we were dealing with a disease in which there clearly was community spread. I mean, in the beginning, the Chinese had mentioned that this was almost certainly mostly an animal to human spread and not human to human. And then they said, well, it can go from human to human, but pretty inefficiently, sort of like the original SARS from 2002. And then as the weeks went by and we had the first case or two here, the question was, could it or could it not be spread efficiently? And then we found out as the weeks and months go by, and that's really one of the problems with this responding to an outbreak like this. In real time, you're learning more and more things. And we learned, first of all, that it's extraordinarily efficient in spreading from person to person, completely unlike what was originally thought, that it went from animal to human and maybe human to human and human to human, not so good. But then all of a sudden, it clearly is almost unprecedented in its ability to spread from human to human. Then the other thing we found out is that a substantial proportion of the people are without symptoms, and that people without symptoms can spread the infection, which makes the already marginal capability in the beginning of doing testing, isolation, and contact tracing made it that much more difficult. So bottom line is we got hit really badly. We're a big country, we're heterogeneous, and we did not have a unified, homogeneous response. We had 50 separate states, some of whom did things appropriately and correctly, some of whom tried to do it appropriately and correctly, but the citizens of their country really didn't pay much attention, maybe didn't believe that this was something that could really cause a considerable degree of a problem because it's so heterogeneous in its manifestations, from essentially no symptoms to being able to kill people with a high degree of morbidity, mortality, and susceptibles like the elderly and those with underlying conditions. So it was a process that was an evolving process. And right now we're in a situation where, as you well know, we have 200,000 deaths and just short of 7 million infections.
And I'd like to start off tonight by getting a sense of, well, the experience the laboratories have had over the past 6 months. Dr. Call, let's start with you. From your experience, how do you think our laboratories have handled COVID-19 response? What have we done better and what did we do wrong?
Well, from the laboratory perspective, I'm actually quite proud of the way laboratories have responded. You know, we found ourselves in a situation where it really took a grassroots effort among the labs to prepare ourselves for this. You know, we'll probably touch on this later, but we haven't had federal guidelines. We've had significant shortages. There weren't existing assays when this started boiling up in January. And so individual labs started working to do what they can to be prepared. And many of them have done immense numbers of tests, as you well know. But there hasn't been, you know, a national standard. There hasn't been the availability of reagents. So it's been a real uphill battle. Despite that, hospital laboratories are doing a significant amount of the testing and are really serving their patients on the front lines of this disease. And I think have had an enormous impact on how individual institutions have been able to respond you know, to this virus, appropriate use of PPE, hospitalization, cohorting, and so forth. But it's definitely been a struggle, and it continues to be such.
Let me ask Dr. Prokop the same question, but slightly different. Gary, tell us, what one thing would you have changed that you think would have had the most impact, and why, as it relates to this pandemic?
Well, you know, preparedness, I think, is the one thing I would change, right? And so Dr. Call touched on some of these. If we had opportunities ahead of time to build these assays, we wouldn't have had to scramble for these assays. If there was greater preparedness with regards to stockpiles and of all the materials that we need, if there was, you know, foresight with regards to earlier deployment of Defense Production Act, for example. So I think it's, you know, preparedness is a large umbrella, but that's the one thing I would change. And I think we would want to look at that, you know, in the postmortem that occurs after COVID-19, that's what we'll want to do. And I think what's really important is, you know, in the hospital, when we do a morbidity mortality conference, it's usually because something went wrong. But we don't do it to ascribe blame. We do it to fix processes. And that's exactly what we'll want to do here.
So let's stick to that. So obviously your day-to-day operations have massively been affected by this pandemic. You know, your triaging of testing as well, et cetera, et cetera. But tell me a little bit more about some of the positive changes that you made in your lab or in your approach to daily practice that you think should be sustained or improved and can help improve patient outcomes even beyond COVID. Share some of that with us.
You know, I think probably one of the biggest things is how the laboratory has become front and center in this. And we've really always been involved in hospital team operations around COVID. And, you know, I think, you know, Karen will likely agree with me. There's just way too many times that decisions are made in hospitals and the laboratory becomes an afterthought. I think we've really demonstrated how important laboratory medicine is. And I think we have an opportunity, if we continue the momentum we have, to push our way to the table in a lot of different conversations, whether it is about diabetes management or, cancer molecular diagnostics. We need to be at those tables, not just have folks assume that the test is being done right somewhere and they can pick which test it is. We're really the testing experts. So I think that's one of the great things that has come out of that, but I think we have to play on it.
So I agree.
Thank you. Karen, go ahead, Karen.
Yeah, no, I was just say I completely agree with Dr. Prokop. And, I think our impact has really been fairly broad. I mean, we all are focused perhaps on PCR testing here, but when I look at, our team handling coagulation abnormalities, the phenomenal work our blood bank has done. We stood up a strong convalescent plasma program at our institution. And so I think there's many examples of where the lab has really made an enormous difference in patient care, in outcomes, as well as hospital finances. We need to continue to remind them of that at every opportunity.
So you're both pathologists, you're both practitioners around standard of care. You're both clearly flying by the seat of your pants as you're developing SOPs and trying to figure out what's the best way to approach this and scale up these tests, right? But would either one of you be willing to share any negative changes or any bad habits that you think that the laboratory community has gotten into out of necessity that we must eliminate as soon as possible once this pandemic has been controlled?
You first, Dr. Call.
Well, I wouldn't say it's a bad habit, but I have found myself, and the entire lab has found themselves, and it's a nationwide phenomenon, making decisions on less data than we've ever had before. We're being faced with committing to large volumes of reagents when we don't really know the test performance, nor do we know if we'll be able to get those reagents. And so I think we've done a lot of things right. We've also done a lot of cross-training and really wonderful things within our labs that we need to continue. But, seat of our pants is a good way to describe it, because I don't think it is as data-driven, as cautious as perhaps we generally operate. And that's been frustrating.
Yeah, and I don't think what I'm going to say is something that we've done wrong. I think it's something that has occurred is, I think we are really burning out our medical laboratory scientists. There's not enough to go around. There's, folks that are actually being denied PTO because we have to run these tests. And so, I think that, looking at that workforce, I know ASCP has done a lot of work around workforce, around reimbursement, around burnout, et cetera. I think that's really important because I think there is an unfortunate, burnout of frontline workers that sometimes goes overlooked.
So, I agree. And one more comment is I think this could be a real core of a campaign to attract, the best and the brightest into medical technology, medical laboratory science, and pathology. I think this is a great opportunity, and you're taking advantage of that already at ASCP.
Have you particularly seen innovative actions or technologies that have seen and been, shared with individual labs that have been adopted, such as, for instance, testing demanding or conserving testing resources or adopting better meeting testing demands, et cetera, turnaround times? Have you seen innovative actions that have been taken, being shared, that have allowed other laboratories to scale up and be more effective?
Yeah, we've had some guest speakers, like I said, non-federal guest speakers from clinical laboratories, commercial laboratories, even academia. And, some of the things that I've heard in those presentations, as well as through comments to our, through the call, Zoom, chat box, whatever you want to call it, as well as to emails to the CDC, we're hearing things like laboratories are using multiple platforms to diversify what they have available to them so that they're not relying on one test and one manufacturer for reagents. We're hearing things about pooling specimens, that's grouping specimens for testing, 3D printing of swabs so that they can deal with the shortage of swabs, making viral transport media in-house. And we've even heard of things like testing other specimen types like saliva, validating those sample types so that relying on swabs, since that's the preferred sample type right now, and most of the assays, PCR assays, are on nasopharyngeal and nasal swabs. bringing another sample into the mix helps with also, addressing that issue with the shortage on swabs. So those labs that we're hearing are validating those assays and submitting them to FDA for emergency use authorization. And we're always willing to hear more from the laboratories, so they're welcome to reach out to CDC through any mechanism, any of our email addresses, and provide information, and we can share that with the community too.
Well, it's a debilitating number to think about, but I want to talk a little bit more about what you just said in terms of the potential for an unrecognized strategic imperative for us to coordinate our response. And as you know, in the laboratory, we have been working vociferously around the clock 24/7 since this pandemic began to develop the appropriate assays to look for, obviously, a diagnostic DNA assay. And then as these EUAs rolled out over the course of the last 7 months, there's 133 out there now. We obviously don't want to run 133 tests in the laboratory. We want to make sure that we can keep our quality control, et cetera. But we'd like to talk a little bit about this national testing strategy, because in the beginning, ASCP and its colleagues looked very carefully at a strong push for a national testing strategy. In your opinion, why wasn't one implemented more immediately?
Yeah, that's a good question, Dr. Holliday. And, I cannot figure out what you would call an acceptable answer to that. Because when you, when you ask, people will say, well, we do have a national strategy. But, in many respects, when you look at how the different states are doing things differently, the thing I keep bumping into when I try to explain to people who are not involved in this why there are so many difficulties and apparent inconsistencies is that we have a large country of 50 separate states. And one of the beauties of the country, and dating back to the founding fathers and federalism, is that you have a central government. But when you're talking about things that are going on locally, the states have the right essentially to do what it is they feel they want to do for their own state. That could work well in a variety of other situations that I don't understand very well. Economic, transportation, things like that. But what happens is that when you get an infectious disease, a highly transmissible infectious disease, boy, that's the great equalizer among states. So if ever there was a situation where you would want people to do things in a uniform, consistent way, which in essence would be a national as opposed to a state-by-state plan, a pandemic is one of those situations. And I don't think that that was necessarily appreciated. And it isn't as if they did things wrong, they just did things differently. And when one state, for example, when we got to the point, which I'm sure you remember very well, when we got to the point where we wanted to start reopening America again, because you can't shut down the country indefinitely. It's not only detrimental to the economy, but it can even have unintended negative health consequences for people to do that. There was varying degrees about how the states approached that. I mean, we put together a real clear guideline. You had a checkpoint in the beginning, and then you go to phase 1, phase 2, phase 3, and the variability with which states accepted that, implemented that, and even those states that try to do it correctly, many of the people in the state or in the city, you would see on television at night, people congregating at bars with no masks, when the guideline explicitly tells you what you need to do. So that really turned out to be a significant problem. The other issue that I think is important is that when you shut down in order to do the physical distancing and to cut down the transmissibility, purely by separating the people from the virus, is that we did that to varying degrees. If you look at the European countries, and certainly the Asian countries, when they shut down, they really shut down. You know, I have a series of slides in a lecture of showing when you track people to see what their movement is, did they really shelter in place? Well, we sheltered in place much, much less than many countries in Europe, and certainly less than countries in Asia. So our baseline never went down to a really low level. If you look at the charts that everybody sees right now, because you could access them, we had a peak. And when we started to come down, instead of coming down to a really low level, the way the countries in Asia and the way the countries in the European Union did, we plateaued at around 20,000 cases a day. And then when we started to, quote, open up the economy and open up the country, that it went up because people did it variably. It went up to 70,000 a day, which is, you know, to put it mildly, is unacceptably high. So right now we're down to around 40,000 new cases a day. Now, the thing about this that is disturbing is that as we enter the fall and the winter, and people will be doing things indoors more than outdoors, we could have a problem unless we get that baseline really, really low. And I think we have a few weeks to a month to do that. And that's the reason why at every opportunity I plead with the American public that it's going to be important to do the simple guidelines: wear a mask, physical distance, avoid crowds, outdoors more than indoors, washing hands frequently. Those things sound almost simplistic because they're so easy to do. And you don't have to shut down the country to do that. You can gradually and prudently and carefully open up the economy while still implementing those public health measures.
Let me ask you about U.S. spending. You think the United States is spending its public health dollars effectively and efficiently? Do you think there's a need to reallocate resources? What do you see going forward, and what might help us bring a solution to this condition? Dr. Call, what do you think?
You know, I would agree. I think it's going to take a concerted national effort to, you know, change how this is done. And that is going to be a slow process, and hopefully one that is not embroiled in politics, but it is upon us to do it. Okay,
so you and Dr. Prokop have both been working with the federal government, with the American Medical Association, even working to ensure that, you know, the right patients are being tested at the right time, and that scarce supplies are distributed to states in a reasonable and rational fashion. Now, given the nation's supply chain issues, what should the federal government be doing to ensure that we are prioritizing testing to the right patients at the right time? Gary, let's start with you.
Yeah, you know, I'll tell you, Blair, one of the things that we've learned, and, you know, Dr. Call and I have been on some of the same calls, is there is a lot going on behind the scenes. And I think we were both shocked on finding out some of the great initiatives that were being done. We just didn't know they were being done, and they hadn't trickled down to our laboratories yet. So, you know, first of all, I'd like to, you know, kind of give a shout out to the folks that really are doing all that work behind the scenes. And this is work to help companies gear up production of everything from reagents to swabs, et cetera. You know, I think it's similar to the question that you asked Jasmine, you know, is the government spending enough money? What is the government doing right now? I think both of these have a same common denominator, is that we're being reactive rather than proactive. You know, we're throwing a bunch of money at CDC right now because of this pandemic. We should have thrown all this money at them, you know, 7 years ago in pandemic preparedness. And so same story here with regards to supply chain issues. And again, this is where this no blame morbidity mortality conference after COVID-19 is over needs to go. How can we secure an adequate supply of swabs for this country going forward if this were ever happening again? How can we assure, and then you can fill in the blanks for every diagnostic and therapeutic and ventilators that we might need, but we need to be proactive rather than reactive.
Well, first of all, Dr. Prokop, by the way, congratulations. I understand that you were recently invited to advise the National Testing Forum that's been organized by Admiral Kuyar at Health and Human Services, and ASCP is proud to have nominated you for that position. So thank you for sharing your expertise with the federal government. And as you mentioned, obviously, you probably can't go into all the details in terms of the operating procedures, et cetera, with regard to that forum, but prioritizing scarce resources is probably the biggest part of that formula. Am I wrong, or?
No, you're right. And I will say they are, really targeting the most vulnerable populations. So, like I said, I think great things are going on behind the scenes. We don't always hear about them. And again, they're not trickling down to, our everyday laboratories. So I'm not saying we can't do better. We can do better. I think good folks are doing as good as they can with the tools they have. It really is in the middle of a firestorm. So, I think we need to get through this, learn our lessons and do better the next time. But, I'm glad to have, gotten a glimpse behind the curtain. And, I think, Dr. Call also did on some of the AMA calls. And again, things aren't perfect for sure, but I think people are working in the right direction.
So you're an optimist.
I am still.
Good. Dr. Call, are you an optimist?
Yes, I've got to be an optimist. I think we all do. But again, we have a lot to learn. And I think we all know this is going to happen again sooner or later, some number of years down the road. We need to be ready, and we need to start thinking about that now. And whether it's funding for the CDC, funding for the WHO, because I do think it's going to take a global preparedness and a global level of communication so that we can avoid what we're doing right now. I think better coordination between hospital labs who have a key position taking care of patients right there in their hospital with the public health labs and the big reference labs. I think they all have a place to play, but we need to have a better exchange and coordination between those, providers of laboratory services. There's many opportunities here, I think, that we can get it right, but we need to start thinking about it sooner rather than later.
And does any of the panelists, feel free to weigh in on this, but the shortage of testing supplies, I mean, clearly we know that it's has reached proportions that we had not predicted, but are those shortages, have they gotten any better than they were, say, a month ago or even 2 months ago? What's your opinion on that and what you see in your practice? Dr. Prokop?
I might want to say a little bit better than, as I mentioned, the kind of chaos we experienced at the very beginning. So there's a little bit of a rhythm to it now. Not as many orders will go unfilled and send us scurrying, but it's still, nowhere near where we want it to be. Dr. Call, how about in your lab?
We've had a couple of near misses with running out of supplies and reagents that still are keeping us up at night. This past week or so, it's been a little bit better, but, it amazes me that we've had to adjust testing for papillomavirus and chlamydia and hepatitis and HIV because these assays are run on some of the same instruments. And so we're really having shortages that affect a broad delivery of medical and laboratory care. And that's been very frustrating.
Well, maybe we could take the lessons we've learned and maybe implement a few appropriate utilization methodologies as well so we can help clinicians understand appropriate testing too. Because we certainly are in a dilemma right now, how to triage patients for care in the age of short supplies. Obviously, the short supplies are likely to be exacerbated this fall. Wouldn't you agree, any of you? Because of the fact that we're going to be facing yet another wave of potential influenza and others. But what are your thoughts in terms of measures, maybe, Jasmine, that we could take or best practices you've learned through the CDC's work so that we can be better prepared for the fall?
This is Jasmine. I'll chime in on this one. First, I wanted to go back to the reagent shortages issue and just comment on that. CDC has been providing reagents to the public health laboratories. That's been our focus. We do that through a program called the International Reagent Resource. And the Department of Health and Human Services, HHS, has been focused on getting materials out to the clinical laboratories. On our last clinical laboratory COVID-19 response call, we had someone from HHS who's leading the team, the testing and diagnostics work group. And this call happened just this past Monday, so 2 days ago. And the transcript is available for anybody who wants to go back and listen to it. But HHS mentioned on that call that they have secured 18 million swabs and viral transport media, and they'll be distributing that. Now, it is being distributed based on state testing plans that have been submitted to the U.S. government in response to the CARES Act, which I already mentioned. Also, the government has been having conversations with manufacturers to understand what's available in their inventory, and they are encouraging laboratories to try to diversify their platforms so that they're not relying on one manufacturer, as I mentioned before. We are using some of the data. I also mentioned the need to send data to public health. And so this data is being used for lots of different reasons. It's also being used to help us understand where there are spikes in testing. And so where there might be surges in cases and where supplies might need to be directed.
I'd like to switch over to Scott for a minute. And Scott, as you know, the Association for Public Health Laboratories, which you are the shepherd for the organization, has a crucial partnership with the Centers for Disease Control in both domestic and international laboratory preparedness. In your opinion, what has been the most valuable aspect of that relationship during this COVID-19 pandemic? And I guess, what has it meant for non-public health laboratories as well?
Great, thanks, Blair. So yeah, we have a long-standing and very strong relationship with CDC from the public health lab community and the association, both domestically and globally. I think that what it's done, our sort of historic relationship, has set us up well to have the ongoing dialogue that we've had. Knowing all the players, knowing where they're coming from, getting good information on a routine basis, and I really do mean that. There is an ongoing dialogue between the state public health labs and the public health lab community and CDC. I think in this response, because it is so large and it's truly unprecedented, there are so many more players that are involved in the response. So there's players at HHS, there's players at FEMA, of course there's players across HHS, and of course the White House and others. So it is a extraordinarily politicized response, but from the perspective of science, policy, and practice, or maybe I should say science and practice, we work very, very well with CDC. I think one of the things that I think about it from a non-public health lab perspective, the states have been engaged since really day zero. We really learned about the experiences on what was going on in China back at the end of 2019 and certainly the beginning of 2020, and began communicating that with the community. Now, a lot of state public health labs also collaborate with their clinical laboratory community in their state, some better than others. But there is coordination, there is communication. Can always be better, absolutely. But I think just that ability to know who's doing what is important. I will say at the outset, there were definitely the challenges that we encountered with the CDC test failure. That set the entire community back. No doubt about that. There's no way to gloss over that. It was a problem. It did put us behind, but I think having the ability to communicate frequently is really helpful, and I believe that's going to only continue as we are expanding testing across the country.
Joya, thank you again. Partners on Health, as you are aware, is leading the contact tracing efforts in Massachusetts. And could you please describe or briefly describe for us what it takes to perform contact tracing Give me some ideas and share with us the challenges to do this in sparse versus densely populated states. You know, give us the overall view of how contact tracing works and the testing strategy associated with that.
Yeah, thanks. First of all, I want to thank the ASCP for always standing beside Partners in Health. We believe that any disease, any epidemic is always going to be worse among the poor, and ASCP has been an instrumental partner in our global work to provide diagnostic services around the world, particularly for cancer in Rwanda, Haiti, and elsewhere. So I want to highlight that because I think for this pandemic, we see that we are only as strong as the weakest link of the chain. And we understand at Partners in Health that epidemics are very, very local. At the end of the day, an epidemic is in a nursing home. It's block by block. It may be an outbreak related to a conference. And so what is important about contact case investigation and contact tracing is to understand the locality, right? So for every case, a new case that's identified, someone contacts them. And if it's in Sierra Leone, that contact is on foot. If it's here in Boston, many of the contacts, most of them are by phone. And then walks through their day. How long have you been sick? And a couple of days before you became symptomatic. And then enumerates those contacts and calls them and instructs them, first of all, if you're sick, and even as we've changed guidelines in Massachusetts, every contact can get a test and is recommended to get a test, and then how they will safely quarantine if they're negative or isolate if they're positive from the people they live with, because most of the spread is within households and among close contacts. And then third is this idea that at Partners in Health we feel is critical, which is giving people the option to say, I can't do that, because we know that social distancing, quarantine, isolation, these are all very economically regressive things that if you don't have money, if you don't have transport, if you don't have safe housing, it's very hard to do that. So if we really want to stop the epidemic, we have to resource the communities, the people, the individuals who are least able to quarantine and isolate to stop the spread. And so contact tracing helps us map where the epidemic is, and it also helps us to resource the places that it is spreading the quickest. And so what that looks like in Massachusetts, Partners in Health is helping the local boards of health in the state. There are 351 of them. And between Partners in Health and the local boards of health in Massachusetts, we've contacted 126,000 cases and contacts. 90% of them we've been able to get through there to and give them this information. And fully about 15% of them need the additional support. And then based on this work, we have been now asked by a variety of cities and states around the country to help them think about this, because as we reopen, this actually becomes more, not less, necessary. And what I would say is that, for example, right now in Massachusetts, the average case has 2 to 3 contacts, maybe up to 5, but people are doing a good job of social distancing. Once we start reopening, then that contact tracing may go up to 10 or 15. And we know that that is why this core of people who can do this function are so important. And let me just say that in countries, even with far fewer resources, who put in contact tracing and supported isolation right away, like Rwanda, they were able to hold from their first 2 cases and going in the first month to only 134. Whereas the state of Georgia, for example, went from 2 cases and in 1 month had 4,400 cases. So you can do a lot once you get your caseload down, and even before, we would argue.
I had a couple comments, and first, I do want to thank the CDC and Jasmine for the calls they've organized. I'm on those as often as a listener and have learned a great deal. So, that's one of the ways that I think we need to figure out how to better share information. I think a big part of what we can do is communicate, and the CDC calls, a couple of the national listservs that our professional organizations sponsor have just been a lifeline, I think, for all of us as we go through this. I think another positive has been the fact that some of the online journals are getting quality manuscripts published and available to all of us much more rapidly than I've ever seen in my career. And again, disseminating this so we can all learn from what other laboratories are doing, I think is really key. And as Gary said earlier, I think we do need to learn from this entire experience because no doubt it will happen again. With respect to the science around COVID, there's tremendous amount we don't know. We need biomarkers. We need to know about the different variations in the genome of the virus, and there's just so much going on right now. I think all we can do is fill our biorepositories and our data repositories with information so that when we have time, when this settles down a little bit, we can go back and look at the combination of biosamples, data, and outcomes, and again, try to put more pieces of the puzzle together so we do have tools for this or other outbreaks in the future.
I think it's an interesting cultural relationship between our country and others as well. And again, it's difficult to compare, the U.S. versus China, et cetera, but they were able to get it under control pretty quickly. And even as you would say, Europe. What's your advice to young people in this country who aren't taking it seriously enough?
Well, I don't know if my advice to young people is, I don't think it's really about young and old. I think it really is, maybe there are some young people who aren't taking it seriously, but I think leadership is critical. In every epidemic I've worked in, and I've worked in infectious diseases for 25 years, and in every epidemic I've worked in, what really changed the paradigm of people accepting the reality, doing the things they needed to do, was really about leadership and the good example that was set by leaders. And so, when we started our work in Liberia, people said, well, Ebola isn't real. It's just like the protests here saying, COVID is a hoax. But leadership is what changes that. And so we've seen very strong leadership in the state of Massachusetts by Charlie Baker. And if you walk around our governor, and if you walk around the state of Massachusetts, nearly everyone is wearing a mask. And social distancing is taken seriously. So I think we need to create the enabling environments. And then many people can't quarantine, isolate, social distance because they need money. They have to work. They have to get out of the house. So how do we enable them to take it seriously? So I'm less concerned about the behavior of individuals than the leadership and the planning that we put in place.
That is a very prophetic comment you're making there. And Scott and Michael, I'd like your opinion. What do you think with respect to changing the paradigm by reversing the trend through leadership? Scott.
Well, I think that it's really about leadership. I think that you really hit it on the head. I think there's leadership at all different levels. We see leadership at the local level, at the village level, at the state level, at the federal level in different forms. I think that we are being challenged. Leaders in the US are being challenged. I see that colleagues across the country and health agencies are leaving their jobs. They're being threatened. I think that is a failure of leadership. I don't mean on their part, of course. I mean on the part of just broadly leadership and allowing this divisive nature to really come across in our country. We really have these divides. We see the divides in the country every day. We see it extraordinarily in fine detail with testing. We've seen it from the early days of testing where communities of color and disadvantaged communities were not able to get tested. So that to me is also, again, a failure of leadership at many levels. So it's critically important that as we think about where we go from here, that we take that into account and we really as a nation, not just as a nation, but as a laboratory community, this is really something that can bind us together. Figuring out how do we get out of this? Where do we go from here so that we don't ever ever repeat this again.
I need to turn to Dr. Mina for his opinion. I'm going to frame it a little bit differently, Dr. Mina. I'm going to ask you to think about what Dr. Mukherjee said, and that is there are segments of the population in the United States that don't necessarily have or not afforded the same threshold of social distancing. I'll give you an example. Yuma County, where the migrant workers are in Arizona, the Native American population portions of Arizona as well, where you're seeing a very large surge in these populations. Partners in Health works very closely with these groups. But in your opinion, what would your advice be around leadership to help curtail this issue where healthcare disparities are more prevalent?
I think, leadership comes in a tremendous number of forms in the United States. It, in some ways it starts at the White House and goes all the way down to, to leaders within households. I think when all of this was getting started, I remember a senator called me up back in March and said, what can somebody in their position do to help out with this epidemic? And at the time I said, I think one of the best things that leaders can do is to start socializing people through their platform and the attention that they get just by speaking, to socialize people to understand that this is a virus that's not going away on its own. And frankly, that the more success we have early on from a public health perspective, that is going to be perceived by the public as something that it's success in public health often makes it look like the threat is less and less important. And so I think one of the things that we can do to try to have leadership that actually affects change in all different communities, whether they're disadvantaged or not, is really to push the message that that we need to remain vigilant. We need to sort of just make it cool to wear masks, make it completely acceptable, and make it awkward to not wear masks. That's if you go out on the street here in Massachusetts, in Boston, if you're not wearing a mask, it feels awkward. And I think that in the middle of a pandemic, that's a pretty simple thing to do if you have it. And so another thing that leaders can do is to give masks away for free, get pots of money and give them, have them available as readily available as possible. They're extraordinarily cheap compared to other interventions that we're putting in place. And that alone will really promote the use of them. It will promote just keeping in mind public health, because mask wearing, it is about personal health, but I think that the act of wearing a mask is also anyone who's wearing it and they don't believe that they're sick, they're fully understanding that they're understanding sort of in some implicit way that this is a public health measure. And I think having the resources available everywhere around us is just incredibly important, and those types of activities can go a long way.
Dr. Mina, thank you for mentioning that. Guy, let me ask you your opinion. Step into the testing conversation, because again, you mentioned earlier that you work so very closely with the CDC, and you found that very useful, as you indicated, in the laboratory community. But there has been a challenge from the beginning, around logistics and supply chain. And what do you think the U.S. needs in place going forward to ensure that maybe there is rationing, or do we really need 4, 5, 6, or 7 platforms running concomitantly in one laboratory against the same test? Can that be avoided? What's your opinion on that?
So I think that we really do need something that a number of us work on globally. We work with other countries all the time on developing a national laboratory policy. We don't have a national laboratory policy in the US. We don't have a national laboratory strategic plan in the US. And I think hearing Dr. Mina talk about the innovations that we're seeing, I think we're going to need regulatory reform. We need fast-paced innovation. But we also need this national policy. We need a way to, again, as I mentioned earlier, bringing the community together so that we can really look at the supply issues. I think, Blair, you're absolutely right. The fact that a number of our laboratories were using 5, 6 different platforms, they had to do that because it was the only way to survive the day, because the supplies just weren't there. You know, we at APHL, we do a survey every week, and we've done this for now, I think 12 weeks. And we ask a question, which is, where are you on supplies? How close are you to running out? And fully a quarter have the potential of running out in any given week today. So there still is this just desperate need to bring, when I say the community, it isn't just the lab community, it's test developers, it's the suppliers. That is going to take leadership. It's going to take federal leadership. We, until the Assistant Secretary for Health, until Brett Giroir was named as the testing czar, as he was in early March, there's no one person in charge of pulling this community together, pulling this system together. We don't think about systems. Now, in laboratories, of course, we do. We think in systems all the time. In public health, we think about systems, but we've never really thought about a national laboratory system. And I think that the strategies that ASCP is pursuing and others really get us much closer to that place, but it is going to come back to the leadership. And I think it's something that has to be done. I think we need to think about doing this, honestly, in the next 3 months. We're going to experience a lot in the next few months over the summer. We're going to experience a lot with flu season and dealing with, you know, the potential second wave, et cetera. But I think there's so much that can be done, but it's going to take everyone sitting down at the same table.
No, I would just like to say, you know, I mean, I agree with everything Scott is saying, but I also have to say, as a person who has spent the majority of my career in low resource settings and now coordinating and supporting the Massachusetts effort and our efforts around the United States, I can say a big problem here is we don't have a health system in the United States. Rwanda has a health system, right? Even very impoverished countries like Malawi have quite good health systems where primary carers report into hospitals, community health workers reach out into the community, the district hospitals feed up into national hospitals. We have an extremely fragmented system at all levels. So it's not just the laboratory. And one of my big concerns, and for me, working in suddenly in this very wealthy country, the United States, with a very broken and fragmented system, has been nothing short of heartbreaking. And I have to say that we could have the best innovation in the world and develop a vaccine tomorrow, and I'm quite sure that the tests or the vaccines that we develop would not get to the communities that are most vulnerable. We see Black and brown people dying at 2 times the rate, getting infected at many far greater. And it's not for the lack of any particular technology, it's because we have allowed this massive economic and social inequality to kind of shape who we are and shape our health system. So we've got to really think about that. How do we pull everybody together at one table, but how do we put equity front and center as we're addressing this terrible pandemic?
You're our expert on contact tracing, that it's really not possible to get to 0 cases using contact tracing, is it? I mean, do you think that's going to be a possibility in the next 3 years?
Look, you can, but what it takes is political will. What it takes is political will, organization, and really for everyone to focus on finding cases, isolating, supporting people. I mean, you know, this is... Yeah, I totally think it's possible. Look, I was involved in the Ebola epidemic, when the last case of Ebola was found in rural Sierra Leone in a county called Tonkalili. Nobody's ever heard of Tonkalili. And yet when you cross this invisible barrier, you would get out of the truck, get fever screened, you know, and everyone says, oh, Ebola was easy. It wasn't easy. It wasn't easy. It was happening in like a firestorm. And we just don't have the will to do these things in the US. That's the thing I think is missing, is the will.
Let me stick with that track for a minute, Dr. Baden, because you mentioned the analogy of this virus, and in particular because it's so unique. But what about the comparison between SARS-CoV-2 and SARS or MERS? And, you know, tell me your thoughts about that. I mean, what do we know, what do we need to plan for in the future as what we've learned from those other viruses and those other infections that might give us some, you know, at least credence to bring some scientific acuity to how to deal with this current pandemic?
I think that the comparison to, so there are, as we all know, 7 coronaviruses that, like people, and have spread widely in people. The 4 alphas are very different biology in that they spread incredibly widely, but caused mild illness. While the 3 beta coronaviruses, SARS-CoV-1, I guess I can call it, SARS-CoV-2, and MERS, are much different in the severity of illness. But I think the biology of SARS-CoV-1 and MERS are quite different from SARS-CoV-2. And what do I mean by that? SARS-CoV-1 did spread widely, you know, upwards of 8,000 people, 800 deaths, multiple cities, hyper-spreading events. But people were not substantially contagious or shedding transmissible virus till days into significant clinical illness. So that it had the morbidity, the seriousness of illness, but not the transmissibility of SARS-CoV-2. While MERS has been grumbling along, in my view, for many, many years on the peninsula and has caused serious disease from time to time, but has not really been transmissible the way that SARS-CoV-2 is. So I think that there are important similarities genomically. You know, there's 80 plus sequence homology between SARS-CoV-1, SARS-CoV-2, but there are fundamental differences in the asymptomatic or pre-symptomatic state and transmissibility, and at what point you become symptomatic. And that disconnect is, I think, one of the treacherous elements that we are struggling with as a community and has led to closure of our community for months.
More of a need for us to look at these zoonotic outbreaks in the first place. And so what preventive measures do you think what might look like after we accomplish victory in defeating this virus? What kinds of roles do you believe in public health will be necessary to prevent these future types of zoonotic outbreaks?
You know, that's a great question, but what it is going to require is global multinational cooperation. Because if a few enlightened countries see exactly what you're saying, there's a number to that. About 70 to 75% of all new infections, namely emerging infections that are new, are zoonotic. Namely, they jump species from an animal host to which it probably, over a period of evolution, has adapted itself to the animal host. And yet, when it gets into another host, it can cause a devastating disease and be transmissible. It is so much to do with how we encroach upon the environment, particularly involving the animal-human interface. So let's just take a look at what we've experienced as a prototypic example. We had SARS in 2002, we had MERS in 2012, and now we have COVID-19 in 2019-2020. It was the wet market interface where people come and do things that are traditional for them. They're not doing it in an evil way. This goes back hundreds of years. They go to the market and people bring in from the wilderness these exotic animals that have turned out to be delicacies that are served usually at festive dinners during feast days. People come, they intermingle, and that's when you get the jump of species. So if we could get sort of international regulations about animal-human interface, I mean, you can't completely stop that, but make sure there are some safeguards, some guidelines. The same thing with the evolution of influenza, where you see in certain countries, chickens cohabitating with pigs, people right next to them, and wild waterfowl who carry influenza. I mean, it's a time bomb for the evolution of new diseases.
Well, having been in the air 180 days a year prior to February of this particular year and living mainly across the world, not sitting at those tables for a while has been sort of a delicacy to me. I've been at a lot of those tables and not having to worry about those transmitted diseases. But once again, when the borders start to open up, I'd like to actually ask you that question about borders. Do you have any idea when Europe, America, and other borders will be able to get back to normal life? Do you think it's going to be pre-vaccine or post-vaccine? And if so, I'll ask you this. Where's the first country you're going to go to?
You know, right? That's a great question, Dr. Holliday. You know, I really have had so much travel, like I'm sure you have, that I'm not very enthusiastic. I really am looking more forward to going to a restaurant or my favorite bar and having a hamburger and a beer before I make the next step.
It's 2025, and we've solved COVID-19. Now reports are emerging of a new respiratory virus in Thailand. What should the immediate response of the U.S. be by the federal government and by laboratory networks?
So we will have learned the lesson. This is the perfect world, right? We will have learned the lesson. So we will have a rotating stockpile of whatever we need. And if it's something that may, you know, rust like a ventilator, we have plans in place to build them quickly. You know, CDC, WHO are all over this. I give Jasmine and the CDC team a lot of credit for this publishing of primer and probe sets. That hasn't been done in the past, so this is a demonstration of progress. And so laboratories, you know, Karen's laboratory, mine, all the reference laboratories have ample opportunity to gear up before this is on our shores.
I think to that scenario, which I wholeheartedly hope for, we'll have a well-funded CDC and representation at the WHO so that we can get samples, you know, again, share protocols, share reagents, share reference materials, so laboratories will have an easier time bringing assays up into their laboratories, and we'll have some idea what the performance standards should be to have an adequate assay. And I think we'll also have a system where, you know, hospitals are dealing with the patients that present on their front door, maybe the less sick outpatients or those who are going to be going to the reference labs. You know, the enormous numbers of samples that go to the public health labs can be shared with the hospital labs. It'll just be more integrated and more functional, I hope, as well.
While we can't say this pandemic is necessarily going to end, obviously, in the next couple of months, it's going to vastly look different than what it looked like 6 months ago. So let's take what we've learned today from these experts about SARS-CoV and COVID-19, that we can help better educate not only our physician practitioners or pathologists, but also our medical laboratory scientists at large. Thank you again for sharing your insight on how to curb this pandemic.